Thanks to you, OF, giving me this chance to present our hospital experience. Partial cystectomy is like an outcast. We don't pay a lot of attention to it in our clinical practice. Because of bladder cancer, could be multifocal occurrence and intraluminal dissemination, high recurrence rate, and risk of upgrading. So most of the time, we choose radical cystectomy instead of partial cystectomy. We analyzed our hospital data and compared with American data. We found that radical cystectomy is performed much more than partial cystectomy. Now I'm going to present our hospital experience from 2000 years to 2013. From our 27 patients, the mean age of our patient who underwent partial cystectomy was 70.6 years old. The mean follow-up time is 39 months. The patient were predominantly male, with a male to female ratio of 5.8. Overall, 63 patients had pathologic stage T1 or stage T2 disease, while stage T3 and stage T4 disease account for 33.3% and 3.7% of all cases, respectively. The most common tumor histology was infiltrating carcinoma. Other histology include papillary, sarcomatoid, and polydifferentiated type. In terms of pathologic grade, high-grade tumor associated for 88.9% of all cases. 14 patients have superficial bladder tumors for which they had previously received TURBT. Among those 14 patients, 11 had undergone TURBT once, and 3 had received TURBT at least twice. Pathologic specimen examination showed that 4 patients have residual cancer at the surgical margin, and 23 patients had clear surgical margins. Significant predictor of overall survival in patients who received partial cystectomy were age and a higher grade T-stage and a positive surgical margin, and a consecutive distant metastasis. The lymph node or distant metastasis rate appeared relatively higher in our hospital, and we thought that's because we don't perform lymph node dissection routinely in the past. About bladder recurrence-free survival, we found previous bladder intravesical installation and a positive surgical margin was significant predictor of bladder tumor recurrence. Patients with a history of more than 2 previous TURBT appeared more likely to have tumor recurrence, although this was not statistically significant. This can be explained by the fact that patient of whom intravesical installation was indicated had a T1 high-grade tumor coexisting carcinoma in situ or a recurrent bladder tumor. These patients are at high risk for bladder tumor recurrence after partial cystectomy. And this is a survival KPI for age. We can find that age is a predictor for overall survival, and the surgical margin, and the distant metastasis after operation. So, in the NCCN guideline, they have a rule about partial cystectomy. The principle of partial cystectomy is clinical T2 muscle invasive disease with solitary lesion and amenable to resection, and no carcinoma in situ, and should be given with neoadjuvant chemotherapy and should be performed with bilateral pelvic lymph node adenectomy. Okay, and our experience is bladder recurrence rate is associated with previous installation and positive surgical margin, and about overall survival, age, higher T stage, and positive surgical margin and consecutive distant metastasis is related. And we should perform bilateral lymph node dissection during partial cystectomy. Thank you very much.
Thank you. Next speaker, Byong Jeong from Samsung Medical Center, Seoul, Korea. Dr. Jeong, please.
Thanks, Chairman. Several years ago, we did a comparative study of oncological outcome in radiation therapy versus radical cystectomy. It was a retrospective design. At the time, we had no established protocol. So anyway, out of a total 144 patients, 100 patients underwent radical cystectomy, and 39 patients underwent radiation therapy. So some patients did chemotherapy, while some patients did not. And between two groups, there was no significantly different in age, sex, median follow-up duration, and clinical T stage and clinical N stage. However, in radiation therapy groups, the stage 40 stage was higher than in radical cystectomy series. And among radiation therapy groups, the percentage of salvage cystectomy was 21%. And it's in overall survival. So 5-year overall survival rate in radical cystectomy was 60%. However, in radiation group showed 45%. In cancer-specific survival, it's similar. Radical cystectomy series had better good outcome versus radiation therapy groups. And in progression-free survival was the same. So at the time, we concluded that radical cystectomy showed better progression-free survival, cancer-specific survival, and overall survival than radiation therapy. So bladder preservation treatment should be done selectively. However, RTOG series showed very good outcome of radiation therapy. Its 5-year overall survival was 57%. It's comparable for surgical outcomes. And also, MGH, they reported that the very good oncology outcome of radiation therapy. Overall survival was 57%. And there are some very various protocol design of bladder preservation. So some institute do neoadjuvant chemotherapy, and some institutes do adjuvant chemotherapy. So since 2016, in our institute, Samsung Medical Center, we established a bladder preservation protocol. So when the patient is decided to have a bladder preservation, and the patient should visit a multidisciplinary clinic. We call the clinic bladder preservation treatment clinic, and also urologist and medical radiation oncologist, radiologist, and pathologist to join. So 5 doctors treat patient. And also we always do neoadjuvant chemotherapy, and the gemcitabine, cisplatin 3 cycle. And after chemotherapy, we evaluated the response using CT, cystoscopy, sometimes biopsy. So if good response is shown, we continue to bladder preservation treatment as radiation. It's a concomitant chemoradiation, but if poor response, we change it from bladder preservation to radical cystectomy. So this is our selection criteria. Usually we prefer small size, early tumor stage, and no ureteral obstruction, no CIS, and it's a good renal function of patient. So in conclusion, bladder preservation should used selectively. However, many guidelines support bladder preservation method. So usually patient want it and seek it. So we should consider bladder preservation treatments. Thank you. Thank you for attention.
Thank you, Dr. Jeong. Next speaker will be Chih-Hsiung Kang, Kaohsiung Chang Hospital, Taiwan. Dr. Kang, please.
Thank you for moderator introduction. My topic is about urinary bladder preservation and neoadjuvant immunotherapy. Chemotherapy preceding cystectomy is a standard care for MIBC. If the neoadjuvant therapy achieved a complete response, bladder preservation may be more and more possible. In this case, the specimen shows no malignancy in the bladder. Bladder preservation may be possible for the patient, but it's too late. Neoadjuvant immune checkpoint inhibitor may be the future, especially for bladder preservation. PL01 is a single-arm phase 2 study of pembro preceding radical cystectomy. All patients had a clinical stage T2 to 3B disease. Patient received 3 courses of pembro 200 ml every 3 weeks. About 40% patients achieved pathological complete response. 51% were downstaging to non-muscle invasive bladder cancer. Most frequent AE were thyroid dysfunction. About 30% had more than grade 3 surgical complications. Most frequent complications were sepsis and intestinal obstruction. The patient with a complete response had a high PD-L1 combined pathological score, CPS, and the tumor mutation burden, TMB. PD-L1 expression and TMB are important markers for predict the response of pembro. The association between gene alternation of DDR, RB1 gene, and the complete response was weakened by adjusting for TMB. In non-responding tumors, post-pembro TMB was significantly lower compared with baseline TMB. PD-L1 CPS increase was not significant. NPMRI for evaluating post-immunotherapy residual disease may be a good tool. Another clinical trial about neoadjuvant atezo for MIBC showed a similar result. Pathological complete response rate was about 30%. Conclusion: neoadjuvant pembro therapy resulted an impressively high proportion of complete response in PD-L1 positive patients. TMB is an important marker. The scores more than 15 mutation in pretreatment tumors predicted association with complete response. Pembro may now be considered an option for cisplatin in eligible patients with a PD-L1 expression or high TMB tumors in locally advanced bladder cancer. I show my case. This old patient received neoadjuvant chemotherapy preceding partial cystectomy. clinical stage T3A N0 M0 status post TURBT and cisplatin-based chemotherapy. The patient showed downstaging to non-muscle invasive bladder cancer, and the partial cystectomy is done. So far so good till now. Another old patient, MIBC with stoma invasion of prostate, status post TURBT, systemic chemotherapy and radiation. Survival more than 5 years. So my conclusion is urinary bladder preservation of locally advanced bladder cancer is more and more possible in the area of immunotherapy. If immunotherapy are safer and more effective compared with system blood-based chemotherapy, why not neoadjuvant immunotherapy in the future? Immunotherapy may make multimodality stages for bladder preservation more and more possible. Thank you.
Thank you, Dr. Kang. Is there any comments or the question in the floor?